Good afternoon, my dear professors and colleagues. أنا هتكلم على الحالة بسرعة. My patient is a 15 years old female patient who presented to the Dembu Cairo University for assessment of delayed puberty. However, upon examination, she had a tenor stage of A1, P1, and B2. Her height was on minus 1.4 standard deviation score, and she had complete female external genitalia. Her karyotyping was 46XY. That was confirmed by the FISH study that confirmed the presence of the Y chromosome in 100% of the cells. Her hormonal profile showed markedly elevated gonadotropins. Her FSH was 100, her LH was 19.8, her anti-Mullerian hormone was 1.2, which was in the female range. Her estradiol and the total testosterone was low. Her MRI showed non-visualization of both ovaries and a small infantile uterus. So to sum up, we have a 15 years old female patient with complete female external genitalia, 46XY karyotyping, markedly elevated gonadotropins, and a female range anti-Mullerian hormone, and an infantile uterus. So a provisional diagnosis of 46XY complete gonadal dysgenesis or Swyer syndrome was made. But we have unanswered questions. Why our patient had a spontaneous onset of puberty, why her AMH was in the female range, and our patient, 1 year before presentation, she had appendectomy for appendicitis, and her surgeon, for unknown reason, he performed an ovarian biopsy, and it showed ovarian tissue with markedly cellular stroma. So we decided to do a diagnostic laparoscopy with gonadal biopsy to answer this question. And the biopsy revealed right dysgenetic ovary, as expected, and the left gonadal biopsy showed gonadoblastoma, which was the answer for most of our questions. Why? Because patients of 46XY gonadal dysgenesis have high risk of germ cell tumors, dysgerminoma, gonadoblastoma, and mixed germ cell tumors that may present as a previous case as abdominal masses, or it may present, as in our case, as a spontaneous onset of puberty. And as in many case reports, all of these case reports presented with spontaneous onset puberty in patients with 46XY complete gonadal dysgenesis. So the key message of all these key reports is a normal pubertal development in patients with Swyer syndrome should be an alarming sign of the presence of a hormonally active tumor. So the management of the patient, we did a bilateral gonadectomy. Her gonadal biopsies post-operatively revealed bilateral gonadoblastoma, although these biopsies are only 2 weeks apart, and the previous pathology showed gonadoblastoma only on the left side, and it was reviewed by the same pathologist. Her tumor markers was normal, and her whole body scan was also normal. She started hormonal replacement therapy, and she's now following with us and with the oncology with regular ultrasound and the tumor markers. But this is not only this is not the final diagnosis, and this is not the final management. Let's take a detailed family history from our patient. Our patient is the third offspring of double first cousins consanguineous parents. The double first cousins are when two brothers marry two sisters. So their children are double cousins. These double cousins share 25% of their DNA. It's the same genetic. It's the same DNA. It's the same genetic material that you share with your half sibling, your grandparent, your grandchild, your uncle, or your nephew. The rest of the family history, our patient has history of previous female sibling death at the age of 16 years with leukemia. Also, her uncle had brain tumor. Her cousin had malignant tumor. And with a detailed history of her older sister, the older sister had also delayed puberty, and she started also breast development at the age of 14 years. Then she started to develop abdominal distension, and she sought medical advice, and her imaging revealed a large left ovarian mass that was revealed by biopsies to be malignant mixed germ cell tumor, dysgerminoma, and immature teratoma. Tumor excision was done. However, 1 year later, unfortunately, she developed acute megaloblastic anemia and passed away. So the older sister has the same double first cousin's parents. She also had delayed puberty. She later developed spontaneous breast development, and she had malignant germ cell tumor. So the older sister can be diagnosed, the same diagnosis as our patient, as 46XY complete gonadal dysgenesis. And our patient is now can be diagnosed as familial Swyer syndrome rather than being the sporadic Swyer syndrome. And according to this review article published in 2024, in the past 15 years, there were 30 cases with familial Swyer syndrome was reported. 66.6% of them had germ cell tumors compared to 45% in patients with sporadic Swyer syndrome. So, according to this, and being the parents' first double cousins with a strong family history of malignancies, whole exome sequencing was done to our patient and her parents, and the results are still pending. And finally, this patient was co-managed by the members of the Dembo Cairo University and the Pediatric Surgery Department, Cairo University, and thank you.
This case is very interesting لأن أنا قريب بقرأ على الجونادال ديسجينيسيس اللي بيديفلوب جونادوبلاستوما فبيديفلوب لوكيميا. It's very common إن هم بيديفلوب لوكيميا لأن نفس يعني نفس البيرنت سيل أو الستام سيل.
ومسك الختام مع دكتورة مروة، اتفضلي معاك. هنتكلم عن delete menarche or something different.
السلام عليكم. أنا دكتورة مروة مجدي نوار، مدرس بيدياتريك اندوكراينولوجي في جامعة عين شمس. النهارده هكلمكم عن حالة هي جات لنا مينلي في عيادة الاندوكراين بتشتكي من delayed menarche، وبس عايزة تعمل الورك اب